This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
Of the chronic conditions, it's one of the more prevalent ones that you're likely seeing in your inpatient setting. This is a patient cohort that is aging, going to require higher care and a higher touch than other conditions, even like other large chronic conditions like type 2 diabetes. This patient cohort is probably going to utilize inpatient care even more than those chronic conditions.
Welcome to SG2 Perspectives. I'm your host, Trevor DaRin. My colleague, Emily Fitt's joining me today. She leads our research into all things in the medicine service line, which means she gets a broader look at the healthcare landscape than just about any of our other service line leads. Today, we're going to talk about COPD. It's been on the short list of big challenges health systems have tried to intervene in the community to solve. But all of a sudden, we're seeing it move up the prioritization list. We're seeing new therapeutics to make an impact and overall an opportunity for care redesign. Emily, thanks for joining. Why are organizations talking to you more and prioritizing COPD in a way they haven't been for a long time?
There's a few things behind this. First is the sheer amount of individuals with COPD in the United States. It's about 12 million Americans that have COPD, and that number's continued to grow. And speaking of growth, on our SG2 Impact of Change forecast, specifically in the outpatient setting, in 2025, we expect there to be 53 million volumes associated with COPD care. And we're expecting that to grow 26% over the decade. So a lot of growth, well above population. This is beyond an aging population story. We do have that aging population that still smokes cigarettes. When we look at tobacco utilization across the country and by age, we're seeing younger Americans are switching to vaping or marijuana use, but older adults are still smoking at the same rates, specifically older adults age 65 and up. The average age of a patient with COPD is 70 years old. It's an aging population. Lastly, there's a value play and there's a health equity play here. As we see a shift, for example, from Medicare fee-for-service to Medicare Advantage, systems are playing in that value space a little bit more. And so COPD is one of those areas where we can push a lot of value by preventing things like ED utilization and inpatient admissions.
Do you have some examples, cases, orgs that really committed to making an impact on COPD as a chronic disease, and they've had some success and have a positive story to tell?
There's a couple different ways that systems can go about this. On the academic medical center side, we have programs like Brigham and Women's who do every endoscopic surgical approach. They do things from lung reduction surgery to lung transplant for patients with COPD, very innovative in the types of treatment options they offer. We have programs like Penn Medicine's Fishman program for home-assisted ventilation. COPD is one of the many conditions that are treated within this program, but basically it's a level below hospital at home, but it's a level above traditional home care. A game changer for post-acute COPD care has been non-invasive mechanical ventilation. You can put a face mask connected to a tube and a breathing machine that the program says is no larger than the size of a lunchbox that a patient can carry around and still be mobile. There's also telemedicine options with this program. Patients can get visits from respiratory therapists and speech pathologists and social workers. What this does is prevents patients from needing a readmission to the inpatient setting because they have that higher level of care already at home. The last one I want to bring up, it's one of my favorite case studies that we've had here a while at SG2. I had to go into the archives for this one, but it's a small rural program in Elkhart, Indiana. What they found was they had a high smoking rate, an aging population, and adults just simply weren't getting screened enough, whether that be for COPD or for lung cancer. What they did, super simple, was they planned on increasing their screening efforts. They established a thoracic institute within their health center with staff that they already had. They trained schedulers to screen patients if they'd be eligible for a lung screen. No new staff needed. They're just adding one additional checkbox to a scheduler's list. And they offered set out-of-pocket prices for those that didn't have insurance. So you could get a lung screening for $200. At the 3-year mark, by implementing these simple fixes, they did more than 500 screens, 2/3 of which required a follow-up of some kind. Some screens resulted in finding a patient with COPD. Some resulted in finding a patient with lung cancer. What that did was patients found all that information earlier, which is better overall for the patient, and it gets the right treatment plan to patients faster.
Having a comprehensive program like that seems so unique. Unfortunately, I have a family experience with COPD. My mother-in-law had it. The system of care she interacted with wasn't good enough, wasn't well connected. How's the system of care around COPD shifting? Sites, providers, technology, therapeutic. How's it all changing? It's exciting to hear health systems are changing on their own, but how's it going to keep changing?
Overall, it's shifting from reactive to proactive, slowly but surely. On the proactive side, we've seen screening guidelines expand for things like low-dose CT scans. We're seeing the lowering of age, the lowering of cigarette utilization. More and more people are getting access to screening or covered screening. We're also seeing primary care take a bigger role in COPD management. A condition that was historically managed by pulmonologists is now more and more. Over 50% of E&M visits for COPD are done by primary care physicians. They're taking a bigger role in the overall management of this patient cohort. And then lastly, thinking about the new innovations and the new technologies specifically for COPD, the one I'm personally excited about is the integration of specialty pharmacy. We have a new therapeutic that had historically been used for dermatologic disorders like plaque psoriasis, was expanded into asthma a couple of years ago. Within the last year, it's now expanded into COPD care. And what's interesting about these medications is they're specifically for patients with COPD that are uncontrolled, that have type 2 inflammation. And by utilizing these medications, we've seen a decline in adverse events, ED visits, inpatient stays, and mortality. So just a new therapeutic that we can help an uncontrolled patient population utilize in conjunction with things like smart inhalers.
Should organizations start redesigning care in COPD around these therapeutics? Are there other opportunities in places where they can probably see return on investment? This is one of many chronic diseases where I think systems are balancing. Where can we make the biggest impact?
A great place for organizations to start is thinking about your current patients. Do you have any frequent readmissions? And what's the reason behind that? When we look at the Vizient Vulnerability Index, adults in the 65 and up category with high social needs are 337% more likely to utilize inpatient COPD care as opposed to adults with better social support surrounding them. What's the reason behind the readmissions? Is there a greater need for higher acuity care in the home setting? Do we need to bring in more support from different staff members? Does social work need to be involved? Do we need to find the patient access to things like specialty pharmacy and these new medications that could potentially help? And that's the second thing. Can you help those uncontrollable patients with new treatment options like biologic medications? And many programs are already dabbling in specialty pharmacy. They're broadening their scope of infusions beyond chemotherapy and cancer into non-medical specialties. This is just something that you can bring under the same umbrella that you do for inflammatory bowel disease, rheumatoid arthritis, plaque psoriasis. From a site of care perspective, these new biologics are provider administered injections. Patient comes, they get an injection, we make sure nothing adverse happens, they go home. Traditionally, the path that we see for these types of medications is they go to self-injectables at home. So a patient will go pick up the medication at their pharmacy, and then they'll go home and then they'll take it themselves. This one might be a slower one to shift because this patient population is aging, frail, has breathing complications. So when you're thinking about your overall infusion facility planning, this might be one that stays in the office setting a little bit longer than other non-medical infusions.
That's really helpful. Pulmonologists are as hard to recruit as any other specialist. Is there a care team shift happening here as well? What does the care team in the future look like with new therapeutic treatments? Is that going to change the role of the pharmacist?
Primary care definitely taking a larger role in this patient cohort. Having primary care be your quarterback for COPD care and utilizing specialists like pulmonologists for higher acuity patients or greater concerns is a way that we're seeing this care team transform. We're also seeing utilization of more ancillary specialists like respiratory therapists who played a larger role in the inpatient setting are now playing a greater role in the outpatient setting with things like pulmonary rehab. Specialty pharmacy is going to continue to play a large role specifically for this patient cohort with increased therapeutics. And that's why I mentioned bringing it under your umbrella of overall specialty pharmacy. It doesn't need to be separate from your other non-medical conditions. You can utilize those resources for all of your specialty pharmacy needs as long as your pharmacy team is leading the helm there. As far as care team integration, AI is taking a bigger role in overall management. We have things like remote lung spirometry tests that can send continuous data to care teams, and they're able to adjust care plans, adjust doses, prevent ED utilization. Getting that continuous remote patient monitoring feedback can help prevent those adverse reactions. And then the last one I want to bring up is the integration of palliative care, hospice care, and chaplaincy, because the average age of patients with COPD is 70 years old. These patients are nearing end of life. And so having those proactive conversations with patients and their families is a part of this condition.
Most of the health system teams that I work with are excited for any new initiative that feels like it's improving patient care. So many of the things we do are around tangentially improving the experience or care for the patient with other benefits. This is so clearly changing what the patient care landscape and value looks like. So make the case internally. You're the leader of a strategy team and you're pitching to operational leaders who have innumerable priorities, financial team, hospital site leaders. Why should COPD move up the priority list?
Of the chronic conditions, it's one of the more prevalent ones that you're likely seeing in your inpatient setting. This is a patient cohort that is aging, going to require higher care and a higher touch than other conditions, even like other large chronic conditions like type 2 diabetes. This patient cohort's probably going to utilize inpatient care even more than those chronic conditions. Cost avoidance is a piece of why COPD care is important. We don't want capacity constraints due to medical patients. We want to be able to fill those beds with higher acuity cases or surgical cases. We are seeing that aging population gravitate toward things like Medicare Advantage plans, where value is a bigger component of payment for systems. Second, we got to think about specialty pharmacy. A lot of organizations are now relying on specialty pharmacy to generate revenue in the outpatient setting. This is another opportunity to utilize specialty pharmacy, not only to generate revenue, but to better the lives of your patients while fulfilling that cost avoidance strategy. And then lastly, I want to bridge back in that hospice palliative care chaplaincy piece. That COPD care is a piece of end-of-life care. It was my very first healthcare internship and a very strong reason behind my why healthcare. I worked with a team of advanced care planners, palliative care, and chaplaincy staff. Understanding that this is a difficult, emotionally charged situation for the patient and their family. And so if that health system and that care team can make the treatment plan and transition that much easier while respecting the wishes of that patient, there is no greater gift you can give that patient and that family.
Emily, really good. Thanks so much for sharing. Thanks so much for highlighting how maybe there's not just one innovation here, but the combination of a few things could and should change the way systems are treating COPD patients. Thanks so much for highlighting all that and sharing your perspective. Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.